So Adam, is there any patient who you don't use a CDK4/6 inhibitor first?
Well, I mean, there are two things. I mean, one, if you're in a resource-constrained area, of the world, where really these drugs are not available, they're very expensive. I mean, I'll give the example of the Philippines, where I was about a year ago. And what they do is they tend to use CDK4/6 for about 4 months on average. And the reason it's 4 months is because it's not paid for by insurance, and the family gets together and they have enough money for about 4 months of therapy. So, you have to really consider that on a more global scale about this. But in our country, in the United States, there are very few people I probably would not give it to. I think maybe somebody with, a predicted overall survival in their lives, competing cause of death, that maybe is less than the benefit they would get from it. Someone maybe who has trouble taking pills, an older woman, maybe, or, who just has a lot of issues and is otherwise frail and has a lot of medicines, is confused with what she's taking, but that's very uncommon. I think one of the issues that really occurs here is the woman who's 36 months or more, after completion of adjuvant therapy. What do you do for her? It's really more than 36 months. Yeah, I mean, so it's like 8 years out. And there are limited data that's a little bit conflicting that with some of the CDK4/6s, there's no benefit. With others, there are. And I think that I would make a nuanced decision on that. I have done both. I have put those women who've relapsed after, say, 8 to 10 years on hormone alone. I put others on hormone and CDK. I think that's just an art decision depending on the volume of the disease, the patient's tolerance, et cetera. But those
It's
are the
interesting.
only people I wouldn't give it to.
With that situation, it's really interesting because the patients I've been seeing more recently who were 10 and 12 years out
Yeah,
received 10 years of endocrine therapy. So those are people
right.
I definitely give CDK4/6
Correct.
inhibition to.
Agree.
It's really interesting. They tend to have a little bit more of, small amounts of visceral disease, I think just because we're treating more aggressively.
Right.
All of our patients will, except for maybe a few, will eventually progress on CDK4/6 inhibitors and hormone therapy. Do you usually rebiopsy? Do you order blood testing? Do you go back to the archival setting? Are you looking for mutations like PIK3CA, Ian?
So, obviously we want a biopsy to prove they have metastatic disease. So they should have an initial biopsy in the metastatic setting. But in terms of after progression on a CDK4/6 inhibitor, we haven't been doing that on a regular clinical basis. There's lots of interest from a research standpoint. We've been trying to get both blood biopsies as well as tissue biopsies to try to understand mechanisms of CDK4/6 resistance. But I haven't been doing it necessarily purely for clinical purposes. We obviously want to know whether they have a PIK3CA mutation, but we typically will get that on their diagnostic metastatic biopsy. It's not likely to change. And the other things were not really going to affect your management very much, so I haven't been doing it.
And then Adam, what kinds of therapeutic options do you present to your patients after they've progressed on a CDK4/6 inhibitor?
Well, there are a lot. I mean, I think the first one, obviously, is what we try to do in a way. We do some sort of blood-based DNA sequencing on these patients at that time, and it's the test du jour, whichever one you like, in looking for the PI3 kinase mutation. And if they have one, they'll then definitely at that point get fulvestrant and alpelisib. But that, as you know, covers about 40% of people. So what do we do with the other 60? I'll tend to think about things like fulvestrant and everolimus is one of my go-to agents. Those are probably the big ones that I would do, my two major choices. I think that there's a little bit of data that's come out. Again, this is not standard of care or FDA approved at this point, but from a bunch of us, I think there was actually a group at Harvard that did Yabardia, us, and I think Joyce O'Shaughnessy, that put together an experience of patients who actually had progressed on palbociclib and then were given abemaciclib, half of which almost immediately after. And it actually was a PFS benefit of about 8 months in the people who got it right after. Now, it's not a huge trial, or it's not even a trial, it's an experience of maybe 80, 100 patients. But again, there may be something to that. I think there's a number of randomized trials that are exploring that very question. One is actually in the Harvard system, where people are doing fulvestrant versus continued fulvestrant, or actually people who progress on an AI plus a CDK are randomized to fulvestrant or fulvestrant and a CDK. So, switching the endocrine partner is an interesting thought. But those are the sort of things that I discuss with people, unless they have truly, really rapidly progressive disease, then I would think of chemo. But short of that, I would really try a hormonal agent again with another target and a targeted agent.
Yeah, and there are also some trials that are thinking about whether immunotherapy helps in specific
Right.
settings as well. In combination, there is some very interesting data with an AKT inhibitor, capivasertib, and there's also some data that will come up with ipatasertib, and that may or may not require a PIK3CA mutation in the tumor itself. And then there's a lot of work going on in managing the toxicity of PIK3CA inhibitor PI3 kinase inhibitor toxicity, including hyperglycemia and rash. So I think we're going to see a lot of additional data in this second and greater line setting in people who recur. And of course, there are a number of studies going on enrolling over 15,000 women testing CDK4/6 inhibitors in the early stage setting. And we hope to see data in the next year, hopefully not delayed by our current pandemic. But I think that that may also change what our options and discussions are in the metastatic setting. This has been a really interesting conversation. I appreciate everybody's contributions to this really important area of management of patients with hormone receptor positive metastatic disease. And now we'll go on to our next case.